The phone rings 4 times before someone answers. Thank you for calling Central Healthcare Services. How may I direct your call? The voice is polite, professional, but they have no idea who your mother is and definitely don't know her and her medical conditions. Contrast that with an experience at a local community health center. Maya at the front desk switches effortlessly between Cantonese and Vietnamese as patients arrive. When your mother walks in, she doesn't need to check her file to remember her grandchildren's names, or that her daughter should be called first if there's ever an issue with the medication. Or when a woman approaches hesitantly, Maya motions to a private area where they can speak without being overheard, a cultural sensitivity she's learned from living in the community for 20 years. This intimate dance of cultural knowledge and personal connection represents something precious in healthcare, something that across America is increasingly being cataloged as quote-unquote inefficient. In his recent Forbes piece titled Sounding the Alarm on the Effect of Call Centers, Dr. Sachin Jain doesn't just criticize, he mourns. He deeply mourns for the Sandras and Lindas vanishing from medicine. Those front desk staff who knew exactly which patient needed an urgent appointment and which family member to call when test results came in. They were more than just schedulers. They were relationship weavers. In their place now, distant voices following rigid protocols, often seated thousands of miles away. Voices that might say, I'm sorry, but the next available appointment is in 6 months, when the receptionist who knows you might have whispered, let me see what I can do, and found a way. The shift feels like a wound to something sacred in medicine. Are we witnessing a necessary evolution or a profound loss? Must we choose between efficiency and empathy, or is there another path forward? Hi, I'm Dr. Raj Sundar, a family physician and a community organizer. You're listening to Healthcare for Humans, the show dedicated to educating you on how to care for culturally diverse communities so you can be a better healer. This is about everything that you wish you knew to really care for the person in front of you, not just a body system. Let's learn together. Today I'm speaking with Patty, General Manager of Healthcare and Life Sciences at Talkdesk, a contact center company whose vision challenges this either-or thinking about personalization and efficiency. Having spent 25 years in healthcare, including pioneering work with ACOs, Patty brings both professional expertise and deeply personal experience to this conversation. When her diabetic mother faced a life-threatening crisis after a cortisone injection, multiple calls to an endocrinologist about her elevated sugars went unanswered. 5 days later, her mother was in the ICU with organ failure. She notes, had that provider had a centralized contact center, there would have been conversations. There would have been escalations. There would have been something more than just no answer. Today, we're venturing beyond simplistic debates to examine the nuanced reality of patient connection. Can we create systems that honor the economic realities of healthcare while preserving its essential humanity? As I said, what you won't hear today is simplistic nostalgia or uncritical techno-optimism. Instead, I hope you'll find something more valuable, a mapping of where we must navigate to create healthcare systems worthy of care. Here's my conversation with Patty. Welcome to the show, Patty.
Hi, thanks for having me. It's really exciting to be here. So a little bit about myself. I am the general manager of healthcare and life sciences at Talkdesk, which is a contact center company. But by background, I've been in healthcare for the past 25 years. I've worked for companies such as McKesson and Aetna. I worked along standing up kind of the first ACOs in our journey to value-based care. So been around in the area for a long time and really have spent a lot of time thinking about how do we automate manual process and help health systems get you a better way of doing things. It's been really interesting coming here to Talkdesk and looking at what was a horizontal company before I got here and being able to actually build a healthcare practice here at Talkdesk.
Yeah, your knowledge must have really helped, especially being in ACOs where one of the primary goals is integration and coordination. I do want to hear about your story a little bit. Could you share how that experience shaped your vision?
Yeah. As you started thinking about these population health aspects and who are the people that you typically tend to focus on and care for, my mom was smack dab in the middle of that and was going through that as we were standing up these first ACOs. So brought a lot of perspective that is a little different than when you just look at things from a third party and you're not emotionally invested. But my mom had all the big chronic diseases. She had diabetes. She had COPD for a bit, obviously high cholesterol, hypertension, all of those different things that you look at as a population that you really want to actively manage in order to help keep them in a healthier way and a healthier lifestyle. And she'd done a ton to really change her lifestyle, quit smoking, eat better, did more exercising, things like that. But she had an issue where she had a really bad hip and it was really impacting her ability to move, which is obviously not a great thing for anybody, especially as you start to get older. And so the decision was made to do a cortisone injection for her hip to relieve the pain and allow her to move better. But one of the side effects of that is obviously elevated blood sugar, which being a diabetic, that can cause big complications. What happened is she worked very closely with her primary care doc, but her blood sugar elevated very quickly and they were unable to really reduce it using the sliding scale insulin that she'd been prescribed from her primary care doc. Her primary care doc said, hey, why don't you go over to your endocrinologist? And unfortunately, as she was trying to communicate with her endocrinologist, they just never called her back. They never even answered the phone. So there was a lot of leaving voicemails. This is a really crucial thing. We really need you to call us back. No one ever did. I was chatting with my father, one of the best caregivers, but very much a rule follower, right? Hey, this is what my doctor told me to do. I got to go here first. This is my next step. And I said, you either go into the office without an appointment, let them know what's going on. I'm sure they'll see you where they can fit you in, or you should probably go to the ER because at some point this needs to be addressed. And when I say high blood sugar, I'm talking about 500, right? Low.
Yeah, yeah.
5 days later, my dad called me 4 a.m. and said, your mother fell. We're going to the ER. Ambulance is here. We couldn't get her back up. When I got to the hospital, she was on that side of the ER where they're monitoring vitals a lot more closely than if she just had a mechanical fall. And when I talked to the nurse, they said her organs are shutting down. So she was actually in the ICU for 5 days as a result of this issue. This was 15 years ago that this happened. So yes, there are some things that we need to be mindful of and think about when we talk about contact centers. But I guarantee you, had that provider had a centralized contact center, there would have been conversations. There would have been escalations. There wouldn't have just been a no answer, no reply type of situation. So I think there's good and bad. There's things that we need to think about and be mindful of. But that story has really driven whether it was the ACOs that I was working on at Aetna, whether it was working with retail pharmacies and the genesis of how medications are dealt with providers, or coming here and thinking about a patient experience. Those all sort of drive how I think about things because of the amount of interaction that I had to have during that time when my mom was alive, right? There was just so much care coordination that goes on. And we in medicine, we're very called to give and to be part of an organization and really work to make things better. That really made a lot of things very complex too on the back end. So it's very difficult to navigate. So I'm always on the lookout for how can we partner better to think about how can we both make it easier for folks to navigate a health system or a payer or whatever area they're interacting, a pharmacy, versus just having efficiencies for the providers, right? Because I think as we think about things in healthcare, the central core tenet for health systems is clinical care, right? It's not consumer experience. As a retailer or an airline or some of these other things, their first focus is consumer experience, right? Because they want them to come back. And I always have to explain to folks who are outside of healthcare that the central tenet is good clinical care, which I think most people, once they're in the four walls, because I can tell you, once we got to the hospital, we felt very cared for. But when you're outside the four walls, it can be really difficult to get that interaction and that experience that allows us to feel taken care of and guided.
Yeah, I can see how the story was so personal for you on trying to fix this system. And I can hear your vision. I agree with you in that there's a nostalgia for the good old times that can happen with a lot of changes. I think part of the, understanding of the call center was the depersonalization and sometimes offshoring of the care as well.
Yes.
And I've experienced this too, where you call somebody, they might respond in 20 seconds, but they are somewhere in India or Philippines. Again, That
Yep.
they're nothing to say about people there, but they actually have no idea. They just have a handbook and they're going paper by paper. So
Right.
then they're not actually able to meet your need, even though they answered the call in 20 seconds.
Correct.
And I think that is vivid for people right now, and
Mhm.
sometimes meshed with the vision of a call center. What a call center meets is offshoring to the lowest, cheapest labor, which is a form of labor arbitrage, right?
Yep.
So what do you think?
I work with a lot of health systems, and I don't have one of them that's offshoring. So
Yeah.
I think there's a difference between centralization and offshore, right? So I think there's a different thought process going on, and not everybody feels the same way, right? So in my estimation, I think it's difficult to offshore because you lose complete control. Because typically when you offshore, you're sending this out to a BPO or something else that is not necessarily as close or manageable. Folks who really have things onshore and are continuing to keep control are also struggling to figure out, how do I deploy this in a manner that keeps that personalization, that keeps the something special about the health system, right? And contains the cost. So I think as we look at the margins in healthcare and we think about what's happening with a lot of these reimbursements, especially as we keep going towards value-based care, and you're seeing these health systems getting hit with penalties and not really hitting the promise of how can we hit the bonuses and allow this to be a good thing for everyone. It's a difficult thing. You work for an organization that actually is one of the first to really do a good job of managing populations and managing that cost, because it's an integrated network across, right? Both the payer and the provider. We don't see that in most organizations, right? They're dealing with multiple payers. There's a lot of just different aspects, and they're judged differently, right? So how do we think about this and incorporate it into an area where we can actually bring all of it together? So as you start thinking about people calling in, the way that things are today is contact center is an ask answer machine. You call in, you ask a question, your goal is to get them the answer, hopefully the right one, and then be done. Right? You say I call in, I need a refill of a prescription. But we don't have any information that we're presenting these agents with that says, okay, you have a prescription need, but you also haven't gotten your annual mammogram, you haven't had your annual physical, you need an A1C check, you need the 8 other things. They're also, by the way, part of your value-based care contract. That if you hit those metrics, you now get 80-90% of your population hit those metrics, you get your bonus payments. If you're under, guess what? You get penalized. So how do we bring some of those things together? We know if they do these things, they're more likely to be able to be monitored, and we can do things earlier in the cycle of the disease to keep them healthier, right? That's why they're the metrics that we look at. So if you can get people to understand these are the things you need to do to manage your chronic disease, that's a great thing. But today we're not doing any of that. Typically, what we do is we stand up a secondary contact center where we have nurses who call out, very expensive resource, who call out and try to get people to answer their phone. And you want to probably hit them with both because but as people are calling in and interacting, we want to take that, I call it a golden moment, when they're interacting with you and trying to take action on their health. We want to serve up that information in an actionable way so that we can get all of those things done at the same time. And as I start to envision, that was a really hard thing, especially when you think about typically contact center agents. You're not necessarily having a clinician or somebody like that who understands all of these things. Now, the precursor for that is to be able to take a lot of these easily answered things off of their plate, because you also don't want to then explode your population of contact center agents you have, right?
Yeah.
But you want to offload a lot of the easy things that they can do in a either automated way, verbally, so they call in, they can speak to a virtual agent. You want to be able to have something that's interactive and that you can have a conversation with, answer the questions, take action, do things, and then allow the more complicated conversations for those populations who do have chronic diseases or are taking care of someone who's more complex. Because if you can do these things, your average handle time is going to go up, which means you're going to need to offload some of the easier things that you can manage. I think with the interactions and the integrations that we're doing with our EHRs is going way up. Now there's a lot of interaction and moving of information both back and forth so that we can document these things and they're there and take care of them autonomously. And then there's also the really great co-development work that's going on with Epic to work through, like, how can we bring these things to light in a way where next best actions are easily doable by the agents. And we can get to that point where you're really guiding people through their care models as opposed to just answering a question, hanging up, and letting someone else make those outbound calls. So that's the vision of where we're going with a lot of this stuff.
Yeah, very important because you're right. When you have that opportunity, we need to take that opportunity to talk about the important pieces of health for patients.
Yeah.
Preventive care, cancer care, all screenings, you name it. And there's a whole host of things, including immunizations, especially in a value-based care model, that we need to deliver on. I think we focus somewhat on the clinical aspect still of what we define quality to be, because part of going back to Dr. Jane's article was on the personalization, not just that it's personalized because you need a mammogram right now because of your age and you have the EHR data, including Epic, to confirm that. You went to a trip to Japan last week and you're coming back. Feeling known is hard in a larger and larger system, especially when there's centralized teams. And that's what I think decentralized, sometimes smaller teams offered. As I said, not consistently or every time, but that feeling. Do you feel like that's replicable in a contact center?
That's a really good question. And I think if you think about where we store the information, and I'm always so impressed with my primary care doc, right? I see her the year, maybe twice a year. And she obviously documents like crazy the personal stuff we talk about. Because when I come in, she picks up right where we left off, right? Yeah. She asks me about my horses. She gets an update. And she's usually typing and looking. She's amazing at typing and talking to me at the same time. Yeah. But that's the thing we all want to feel. We want to feel known and heard. And that's where I think some of these CRM pieces come in. Typically, we only do that. We only do the clinical aspect of things in our EHR.
Yeah.
And you don't necessarily want that in the clinical record, but you do want a spot for that so that as someone's coming in, we understand who they are and we can mention those. And I think that we all probably have played with ChatGPT and other large language model things.
Yeah.
And you can see how they can respond and ingest information like that and bring it back out in ways that didn't used to work, right?
Yeah.
You wouldn't be able to feed a model that's available for consumption, whether that's to the agent in the co-pilot methodology where you're like, hey, make sure you ask about this or this, right? Here's the things we know about this patient. Or if it's an actual automated agent who can actually have the conversation and bring those things up as well. And then bring that information back into the CRM, customer relationship management software, that allows you to document interactions and get those little personal nuggets that are so important to make us feel known and incorporate them as part of a conversation to build that trust. Because I think it's important, right? That you are heard, you're known. So my answer to that is yes, we can, if we're doing the things that we should be doing with documenting and stuff like that. Not everybody documents that stuff, right?
Yeah.
So that's the key, because even if you have a local person, you didn't document that stuff and you only saw them once every 3 months, you're still not going to remember all that likely. There's a few people who do that, but very few. Most of the time, people are taking really cool notes and putting them in a place where they go, oh yeah, that last time we spoke, we talked about XYZ, right? I know they have kids and here's their ages and what their sports that they play are or what their interests are. That's not done by memory. We're documenting that stuff.
There was one piece of this conversation I want to build on is that we talked about CRM for our patients that we're talking with. I think another piece that maybe wasn't explicit is that there's a CRM for clinicians too. Of when there's a front desk that's local, they know the clinician's preferences, ability, capacity, priorities to ensure which sometimes is lost in a contact center. Is there a way that you feel like that can be changed too? Because we did focus a lot on the patients, but is there be like, oh, this clinician will definitely see somebody that's urgent because that's how they treat their patients, right?
Yeah, it's really interesting because I've been going out of my way to have more conversations with physicians. I think that when we think about adoption of this, the biggest resistance tends to be from the physicians. It's their practice. They want to make sure that their brand is represented appropriately and that they're not being flooded with appointments that aren't appropriate for them or not given enough time or given too much time. There's obviously the balance of monetizing what they're doing as well as just being able to practice the way they want to practice. And I had a great conversation with the vice chair of medicine at UNC Health the other day, just talking about this exact thing, which was really fun because I wanted to understand a little bit more from that perspective, what they were experiencing, what he's experiencing. He had a very specific niche practice. He's in an academic medical center, right?
Yeah.
I see this kind of patient. So it's really important that I'm not scheduled with patients that are outside what my practice should be seeing. So I think that as we start to get more of this knowledge base documented and understood, there's going to be a lot more ability to ingest this and to be able to utilize those types of decision trees. Because I would look at this as a decision support mechanism, right? Hey, look, this patient matches this criteria. And being able to look at that. Because I know today what usually happens when you've got, especially, I'll just call it the ologies, right? You've got a referral to a specialist and they need to make sure that this is the right doctor in that specific practice. Because let's just take an easy one with an orthopedic. Some people are wrist specialists, some people are elbows. You need to match that patient. And then you need to make sure that the insurance covers it, the prior authorizations are done. There's a lot of things that need to happen in order to make sure that patient can come see that doctor, get it reimbursed appropriately. They understand any out-of-pocket costs, all of those different things. So everything is done. There's a lot of complexity there. So are we there today? No, absolutely not. What we would do today is basically escalate a lot of those to a human. The human would then have to ask all those questions and make sure that they have all of those things done. They'd have to make phone calls or electronic prior authorization requests, make sure it's been approved, all of those things. I think as we move forward and we get more of these large language models moving, the ability to ingest that information and know the information they need to get from the patient. So if they're a new patient with a referral, we know we need to ask XYZ, right? Or there may be some ability to send information out so that the patient can then put that information into a questionnaire. I don't think any of it's precluding doing it centralized. But I think it needs to be more mindful and thoughtful about how we go through all of these things. And I think the technology is getting so much better to be able to empower those central call centers to do it correctly so that you're not having to send everything out to the individual practices.
Now, transitioning to the equity piece that we focus on, I think the transition here is we focused on individuals a lot, and a lot of equity is on group identities. Especially groups that have historically experienced distrust from healthcare because of just prior negative experiences. And somewhat in our current model, and this front desk model, I'll just call it that, is that local community health centers have people who are part of the community, who speak the community's language, who's lived through what the community has gone through. And there's also nostalgia for that when we're moving towards call centers. So how do you envision maintaining trust in these situations when things are centralized and you don't know the person actually understands you?
I think it's really interesting because when we think about centralized, I think pre-COVID, we thought about everybody sitting in the same room, in the same location, and they were all in this mass contact center. When you think about centralized contact centers today, just because we think of them as the similar group, doesn't mean they necessarily sit in the same place. A lot of times they're in the neighborhoods, right? They're people that you hired from those areas. And we work with a lot of different sort of equity programs that are out there, especially with the Medicaid populations and things like that. And a lot of the distrust is in those populations. They hire people who are from there that have the language, they have the cultural identities as well, and able to do that. In a lot of those cases, what we're doing is we're using that co-pilot AI piece to make sure that we're empowering those agents with all the information that they need, that they can then have the conversations and do the things that they need to do in the way that is best received by those populations. So there's a lot there when it comes to just empowering the agents, not necessarily automating things, because we know we tend to have some issues with distrust of entering a lot of information into computers. It just is a thing. So I think being able to do it in a different way, but still allow some efficiencies to happen is a really important aspect of things. I think that as we start to move down the line with some of more of the automated agents, the ability to actually listen and respond in the language that the caregiver or the patient is speaking in is so much better than it was. We're showing some things today where you're speaking English and then switch into a different language and it goes right with you. and can be a lot more casual and less robotic. I think it's getting better as we start to do those things, and we'll see. But I think the ability to learn and have more empathy, these models, honestly, sometimes are better than the humans that are answering us.
Many times, I think I've seen research to show they are, because they're not human, and that humans have bad days. I have bad days, so I'm not my best self, of course.
Exactly. And when you yell at the person, that person has a response and gets upset. So the AI is just going to go, I'm sorry, I didn't.
All of that. I think one thing to call out here explicitly is that the benefits of centralization call center is to take advantage of technologies which can be prohibitive for local teams to use because of investment costs and just upfront investments that needed for something like that, especially things that you're talking about. Because I've thought about this idea. I used to see this all the time for the United Nations when they're interpreting. It's like instantaneous. So you actually have a real conversation compared to the patient conversation that I have, where there's a long pause and I'm just sitting there. I have no idea what's happening in between, rather than feeling like a conversation. But I think with technology, that can be actually accessible for a lot of folks.
Translator from Star Trek is
exactly. That's even better. So with communities, I think there's that cultural concordance that you spoke to.
Mm-hmm.
Part of that is also values that certain communities hold. And in this article, I think there's several points there. One of them was the understanding of family dynamics. Absolutely. I think it could certainly fit into your vision of personalization that you already spoke to.
Yep.
The question is, when there's values that are maybe not the standard, and certain communities have more family-oriented values, community-oriented dynamics, more family caregivers, and when we're attempt to centralize any decision-making, we need to establish a standard of care and a standard protocol. Mm-hmm. So when that's done, sometimes there's such a black and whiteness to it of what the protocol is. So it's not that nuance, especially for family dynamics, right? It's just feels like I don't know what to do in this situation. So I'm just going to default to what this says, which is I can't actually share anything else with you.
I'm working with my brother-in-law and sister-in-law on my mother-in-law right now, who's having a lot of problems. And I had to call in to an organization, the one you're working for, and had to have a conversation with that. I wanted to get to a social worker. I wanted to have what are the options that we have, right? Here's what's going on. What can I do? There was at the first, I can't share anything. The caregiver has to call in. And I said, okay, how about we just take anything HIPAA related out and we just have a conversation about options, right?
Yeah.
And so I was able to start them down a path that allowed us to get some additional care resources for my mother-in-law after her fall. So I think it's very interesting. And this isn't cultural or not. A lot of times when we don't know the answer, we just shield ourselves with HIPAA.
Yeah.
I can't do this or I can't do that. So I think there's so many different layers of things that we need to think about as we go forward here. And how can we just lend help, right? In a way that allows people to access the resources that they require. And I don't know that any AI or any of those things is the answer for that, because we've spent so many decades building this complexity into healthcare that I think we need to really seriously take a look at and figure out how do we centralize and think about there's these different things, but then when do we step back and say, what are the things that are just universally true that we should offer? It could help someone make better decisions. So if you need a social worker to get involved because you've got family dynamics that are complicated as well, you've got a divorced set of parents and they're contesting who has authority to make decisions for the child. We do a lot of work with a lot of children's hospitals. There's a lot of different things that end up coming into play when you get family dynamics. And then you got cultural aspects that you can start to layer on top of that. There's a lot of things that probably need work. That's where that co-pilot piece that I keep talking about comes into play, where we're listening to the conversations and offering up information that an agent can use, where you're taking a look at some of these dynamics and saying, if we see this, these are the things that you can offer as a helpful aspect. Because I think that's an area that I'm really passionate about, because as we think about some of these populations who traditionally haven't even been able to even know they should ask for help, that's a big deal. And I think language barrier has been a big part of it, because you've got usually a younger person in the generation who's trying to translate for the parents or the older folks, or you've got just a translator in the middle, and they're not necessarily healthcare workers. They're just a group you've hired to do the translations. It's important that we start to be able to listen in the language that is being said and then translate in the language that's being spoken back, that I think is going to bridge some amazing gaps, I believe.
Okay. I think piggybacking off what you're imagining, I also think of cultural specific health education. For example, I heard somebody talk about your example at the beginning. You talked about cancer screenings. So when we're talking about mammograms and cancer screenings, a community specific conversation wouldn't just that you need a mammogram, breast cancer screening is important, is somewhat of an assumption here in the United States, but in other countries, preventive care is not the standard, nor is regular cancer screening. So understanding there's actually another level of conversation, which is, let me just talk to you about cancer screening first. This is why that's important before we get to breast cancer screening. And I think there's more maybe capabilities for that's coming out.
Agreed.
I think in one of the articles you mentioned this proactive outreach capabilities.
Yep.
So what are you thinking of when it comes to culturally specific health education?
First of all, I love that thought process of going back to what are the areas where I think being able to look at data and say, what are the populations we're not reaching? And then being able to do some understanding of that. There's some great analytics out there today that can help us identify the populations we're not necessarily reaching. And then being able to layer that in and look at it like, hey, is this a cultural issue? Why? And what can we do as far as putting together information that can then go to these different populations is great. And then what we can do as contact center piece is to be able to point people in the right direction, knowing what's going on of these are the things we need you to take a look at, whether that's an education module that they can go access on the computer, or whether that's, hey, we're going to bring you in. There's classes that people newly diagnosed with X, we want them to come in and do Y. Here's the reasons why we recommend these vaccinations for the population, right? Because that's probably also something that not all cultures are used to is the large amount of vaccinations that we have our infants go through. That could be a scary thing. So being able to help them understand this is the reasons why before we just start signing them up for things that they don't show for. They're not used to it, right? So I think there's some interesting opportunities that we could do around that. But again, I think as these different pieces of AI kind of pop up and allow us to think about things in a little bit more uniform way, and they don't cost as much to do, Vietnamese, right? Because there's a different way of speaking there and the different way of looking at things there versus Cambodia. You can't just put all Asia into one giant pack.
What's your vision for how contact centers could transform healthcare access for diverse communities in the next 5 to 10 years?
Yeah. So I do think that the biggest thing is going to be this co-pilot capability of being able to coach. I think being able to be more connected in with understanding what's going on with our populations and provide ways to do more proactive outreach as opposed to being very reactive. I think as people are calling into being able to proactively have conversations in the language of choice, right? That real-time translation piece is going to be a thing. It's going to be much easier to do, and being able to have those conversations correctly for the person who's calling in and truly meeting them where they are, I think is going to be great. We want to bring it all so that as you're interacting, you're getting that information, you're acting on things, that should be a win for everybody in the real world, right? We should have healthier populations because they're taking advantage of the things they need to do to stay healthy. The providers are getting their reimbursements appropriately based on these value-based care contracts. People are staying healthier. I envision, call me an optimist, a place where we get to where it becomes just easier to do and know what you should be doing to keep yourself in a health and your family in a healthier state.
Thank you so much, Pat, for coming on the show. I really appreciated it.
Great to talk to you.
As always, thank you for listening to Healthcare for Humans. If you've found any value in this podcast, I have 2 quick requests. 1, please leave a review in the podcast app that you're listening to my voice in right now. It really helps others discover the show. 2, share this episode with anyone who you think might benefit from it. For easy access to all our episodes and to support the podcast, visit www.healthcareforhumans.org. There you'll find our content clearly organized by topics, countries, themes, to help you choose what to listen to next. Until next time, this is Dr. Raj Sundar, reminding you that culturally responsive care leads to better patient outcomes. See you again soon.